Arfina, you may start right now.
Yeah. Okay. A very good afternoon to everyone. My name is Arfina Ara Hussain, and I am a research intern at ICS. On behalf of ICS, I welcome you all to today's Wednesday seminar. The topic of today's discussion is epidemic control, social control, the rise of an emergency disciplinary state in Mao's China. The talk will examine the relationship between epidemic control and social control during the global cholera pandemic that plagued the southeastern coastal areas of Mao's China between 1961 and 1965, when China was suffering from lingering starvation, class struggles, political campaigns, and the geopolitical challenges of the Cold War. The speaker for today's discussion is Fang Xiaoping. He is an associate professor of Chinese Studies in the Faculty of Arts at Monash University, Australia. His research interests includes the history of medicine, health epidemics in 20th century China, and the socio-political history of Mao's China after 1949. Joined us as our chair is Rama V. Baru. She is a professor at the Center of Social Medicine and Community Health, Jawaharlal Nehru University, and an honorary fellow, Institute of Chinese Studies, Delhi, India. Her research interest includes commercialization of health services, infectious diseases, comparative health systems, and health inequalities. Before I hand over to the chair, I would like to request all the participants to follow some housekeeping rules. Please keep yourself muted during the session. You can unmute yourself only when you are asked by the chair to do so. You can post your questions in the chat box, or you can use the Zoom raised hand option. With that, I hand over the floor to the chair. Over to you, ma'am.
Thank you very much, and good afternoon to everybody. And a very, very warm welcome to you, Xiaoping, whom I met at a conference in Norway on the history of social medicine. Been fascinated with his work. In fact, your book has been reviewed by the Institute's journal, the one which you wrote on barefoot doctors. And I want to say that this particular talk is very, very important and very opportune, because as we look at the COVID pandemic and its unfolding and its control, etc., I think history, we can really learn a lot from history, and we can look at how systems evolved for its control. And a lot of it has to do with not just the epidemiological control of diseases or the health service response to control of diseases, but it actually affects the movement of populations, the reconfiguration of spaces, and the questions around the socio-political control, that those mechanisms that come to play, in which case the entire discourse of epidemic control goes much beyond the boundaries of medicine, public health, and epidemiology. And I really think that this is a particularly opportune moment to hear Xiaoping, because in the book, and I'm going to show you all the book that he has published, and sorry, it's a bit inverted here, but the title of the book is China and the Cholera Pandemic and Restructuring Society under Mao. And I think a lot of the ways in which the COVID pandemic response was fashioned, there were continuities from the Mao era, and even the idea of lockdowns as I see a very important measure that the Chinese government, in fact, gave to the world, has some kind of ideas that really were part of the Mao era, and especially through this lens of the cholera pandemic. This is a very, very detailed, wonderfully written book. I enjoyed it, Xiaoping, and I thank you for having gifted it to me. And without further ado, I will request you to please make your presentation. Thank you so much.
Okay. Thank you all for attending my talk, and thanks for Professor Rama Baru's kind introduction. It's my great pleasure to give a presentation at the Institute of Chinese Study. The COVID-19 pandemic has a ravaged the world over the past 3 years. So now it's time to say goodbye to this unprecedented pandemic, which has already turned our life and the work upside down. In recorded history, every pandemic has ended or subsided with humankind living with a disease. As in other parts of the world, deadly pandemics have ravaged China throughout its history due to population mobility and displacement resulting from wars, trade, socio-political restructuring, and globalization. And deaths from the epidemics and the pandemics were much higher than those caused by war and rebellions, such as a plague and the cholera in the end of the Ming and the Qing dynasty from the 14th to 20th century. But it was very difficult to have the accurate statistical data of this epidemic disease. So after the founding of the People's Republic of China in 1949, population movements due to socio-political restructuring, radical political campaign, urbanization, and globalization triggered the outbreak and the spread of the pandemics, such as the pneumonic plague epidemic in northern China in 1949. And the second most deadliest pandemic is cholera pandemic in southeast coast of China from 1961 to 1965. That's the topic of my today's presentation. And I think most deadliest pandemic in China after 1949 was the epidemic meningitis, which broke out from the 1966 to 1968 during the early stage of the Cultural Revolution because of the movements of the millions of the Red Guards, young Red Guards. And then the SARS in 2002 to 2003, and the final one is the current one, the current COVID-19 pandemic. So in this study, I focus on the global cholera pandemic in China from 1961 to 65 and analyze the dynamics between the disease and the social restructuring between the Great Leap Forward, which is associated with the Great Famine, and the Cultural Revolution. So they were, as we all know, they were the two most radical political events of 1960, both of 1960s and the most China, I think even the 20th century China. In 1961, Alto cholera epidemic broke out in Sulawesi Island, Indonesia, becoming the 7th global cholera pandemic in recorded history. In China, Alto cholera first broke out in Guangdong province in June 1961. So that's in June in 1961, the Great Famine was still lingering in China. Indonesian Chinese had returned to China during the archipelago's pandemic, escaping political, economic, and racial tensions between Indonesian and Chinese, and were immediately suspected cholera carriers. The cholera was controlled in Yangjiang County, Guangdong province by September 1961. However, the disease re-emerged in Guangdong in February 1962 and quickly became a pandemic, one that mainly affected the southeast coast of China, spreading rapidly through Zhejiang, and then come back to Fujian, and then went northward to Shanghai and Jiangsu from July 61 to 65. Here's Sulawesi is here. So the Yangjiang County is around here, so a little bit far from Hong Kong. And then in July 1962, the cholera broke out in eastern Guangdong province. which is next to Fujian province. So that's the general route of the transmission of the cholera pandemic from Indonesia to southeast coast of China. The 1961 to 1965 cholera pandemic broke out and spread through southeast coast of China in a very specific socio-political context. It arrived in China at a very delicate time when the devastation of Great Famine of 1959 to 1961 was still lingering. In local politics, the Chinese government committed to social restructuring in order to overcome the political crisis and reconsolidate the legitimacy of its rule. As crucial steps toward this, the government reformed and restrengthened schemes for controlling the population mobility, creating the organizational units such as the work units in urban areas and the people's commune in rural areas. They were the two basic organization units in grassroots society. And then undertaking the social surveillance and conducting the political indoctrination, such as a class struggle, emphasizing class struggles, and further implementing the economic strategies and the policies that it had initiated in the early 1950s. And at the same time, it consolidates the strict division of Chinese society into rural and urban areas. This social restructuring in the early 1960s brought about a transition from the chaotic population movements that was characteristic of the Great Leap Forward years to orderly mobility in the more sedentary and post-famine society. So the population mobility during the Great Leap Forward was quite chaotic, but now the population mobility was under control of the government. The state dominance of the work, life, production, and consumption brought about by the social restructuring of the 1960s continued largely intact throughout Mao's China until late 1970s and early 1980s. Anyway, just before the end of the People's Commune system. This socio-political change was intensified and complicated by the geopolitical roles of China within the international community at the peak of the Cold War. In this international context, China experienced the reshuffling of its geopolitical and ideological interests and clashes with the allies, neighboring countries, and areas in Southeast and Southeast, South and East Asia. So different parts of the Asia. This included the Indonesian Chinese nationality issue and the Chiang Kai-shek's military preparation for reclaiming mainland China in Chinese. That's 反攻大陆. This external environment both challenged and reinforced the social restructuring process. So that was 60 years ago. So 60 years ago, there was a great pandemic, and there was a military confrontation between the mainland China and Taiwan. So 60 years later, we experienced the pandemic and experienced the military confrontation. So history repeats itself again and again. So my project investigates the dynamics between disease and the social restructuring in the significant transitional years of Mao's China, just between 61 to 65. So that's the significant years of Mao's China. So my study seeks to examine the questions in three aspects, including the disease and the mobility, social divisions and the borders, and the third is data and the social structure. I choose to center my study on Wenzhou Prefecture because the cholera instance there was the highest in the southeast coast of China, according to the available statistical data of the cholera epidemic. And Zhejiang was also among the provinces, southeast coast of China province with the highest instance of the disease out of all those affected by the cholera at the time, including Guangdong, Fujian, Shanghai, and Jiangsu. Furthermore, Wenzhou's large coastal region and extensive river and delta access have endowed it with a specific geopolitical significance since the 1950s. The nationalist governments based in Taiwan regarded it as the bridge across which it would reclaim the mainland, while the communist governments in mainland China identified Wenzhou as the frontier of anti-imperialism and anti-Chiang Kai-shek groups based in Taiwan. So the military confrontation between the nationalists and the communists reached its peak in 1962, precisely when the cholera pandemic was ravaging Wenzhou prefecture. So Wenzhou was a coastal front society within the wider Cold War in Asia. To further complicate this, Wenzhou was a major point of origin for overseas Chinese from Zhejiang. Immigrants from Hong Kong, Macau, and Indonesia, Singapore, and Malaysia visited Wenzhou throughout the 1950s and 1960s. Zhejiang was not the hometown of the majority of overseas Chinese, but it has a lot of the overseas Chinese around the world. So now let's look at the emergency response scheme. So right after the outbreak of the cholera pandemic, the disease, the Chinese government launched a large-scale but clandestine campaign, clandestine emergency response campaign, which included interventionist measures such as lockdown, quarantine, isolation, and mass inoculation. And the second is the epidemic surveillance and the information control. So information control was a very unique practice in China's epidemic control practice. So when China was an isolated nation in the globalized health community during the Cold War, I will discuss the China as a isolated nation in this context later. It should be noted that the alto cholera often appeared in a mild clinic form and resulted in many symptomless carriers moving around while unaware that they were spreading the disease. So it is little bit different from the COVID. Indeed, the majority of the individuals infected with the cholera either had no symptoms or just showed mild diarrhea. So for classical cholera, the ratio of the severe cases that required hospitalization to either mild or asymptomatic infection is 1 to 5 to 1 to 10. For alto cholera, this figure reached to 1 to 25 to 1 to 100. So furthermore, both the quarantine and isolation were not advocated by the international and medical and health community, such as World Health Organization. By the early 1970s, the World Health Organization had explicitly pointed out that the mass inoculation was usually of no much help for cholera control. And the similar cases were plague and tuberculosis. I think our colleagues have already conducted the research on this, on the plague and tuberculosis. So now let's look at the quarantine and isolation. A week after the first cholera case was confirmed in Rui'an County in July 1962, the Zhejiang Provincial Health Department issued its first circular on the cholera quarantine. The cholera first broke out here. This the small is a river and is a unit. The provincial government divided the Zhejiang province into 3 zones and assigned different control and prevention duties. In this way, the Zhejiang provincial government partitioned the whole province into a series of the concentric circles that centered on the cholera-affected Wenzhou area. Within these geographical zones, the provincial government set up a major observation stations along the railway lines. In the meantime, a series of high mountains that were located between Wenzhou and these quarantine belts form geographical barriers. In addition, because cholera mainly spread by the fishermen from the Guangdong and the Fujian province and some from the Shanghai and the Jiangsu, the Zhejiang provincial government set up a temporary joint quarantine station in 3 major archipelagos of Zhejiang province. In combination with the railway and the geographical belt on land. So they formed the first quarantine ring around the Wenzhou. So within this quarantine ring, the provincial governments formed the second and the third rings of the quarantine control mechanism, along the major highways and the maritime roads that are connected the Wenzhou to other parts of the province and other southeastern coast provinces such as Fujian and Guangdong. Within these 3 quarantine rings, the county and the city governments further divided the quarantine zones from the county level down to that of the districts and people's communes on the basis of the existing administrative structure. So the infected and the neighboring areas were further classified into blockade areas, semi-blockade areas, and the control areas. So this practice sounds the same as the current practice. So different zones, different functions, and different regulations on the people's population movement. This is the practice of the quarantine and isolation. So in my study, I investigate the rise of the multiple borders, including the natural borders such as the mountain and the rivers, and the administrative borders such as just mentioned, that's a socio-political administrative structure, and the militia borders and the quarantine borders. And these borders' significance on the reciprocal interaction between the interventionist prevention measures and the social restructuring during the pandemic in 1962 to 1965. My study shows how the socio-political restructuring prior to the pandemic led to the rise of invisible administrative borders based on the visible and natural borders through the compositional homogeneity, political surveillance, and economic egalitarianism. The quarantine scheme further reduced the administrative border through the partition and encirclement, while the quarantine station interwove these nature, administrative, military, and epidemic-related borders and created a very tight surveillance network. So my study also shows the problems around the quarantine of the suspected cases and the isolation of infected patients during the cholera prevention work. The principle of the on-the-spot isolation, economic presence, particularly the presence of economic concerns, and the fear of the contagion shape the distribution features of the isolated patients, which reflected and re-strengthened the rural-urban hierarchy by containing the population mobility. However, the isolation process itself become a potential sources of the contagion due to the poor medical facility and unfair resources distribution. Similarly, quarantine scheme further contain the mobility of the sedentary population, regulated the movements of mobile populations, and monitored activities of the population deemed dangerous, such as the political enemies, so-called political enemies. However, the quarantine was ineffective at identifying atypical patients and suspect carriers, given the features of the cholera transmission and the condition of the medical health facilities in 1960s. So the quarantine and isolation that's greatly strengthened the contours of a newly restructured society. So I argued that the interventionist scheme to control the pandemic not only harnessed the opportunities provided by the broader social restructuring initiatives, but also directly contributed to these efforts and significantly facilitated the rise of the emergency disciplinary states. Mass inoculation was another interventionist measure adopted by the pandemic. That's the very traditional measure. In the early 1960s, the Chinese medical experts believed that some Chinese medical experts believed that only when 80% of the total population were inoculated could a community achieve adequate immunity against the cholera. But the other Chinese medical experts disagree with this viewpoints. Accordingly, on August 3rd, 1962, directives from the Zhejiang Provincial Party Committee and the People's Government ruled that the entire population in each county of the Wenzhou Prefecture had to be inoculated before August 15. So the emergency inoculation initiative meant a total inoculation campaign in which local governments had to inoculate a total of the 2.94 million people within 12 days, less than 2 weeks. So that was early 1960s. So these are emergency pose serious challenges for local governments in view of the very limited time frame and the extent of their duty, the serious of the shortage of the medical personnel. At the heart of the problem lay the requirements to secure the accurate population information and coordinate the professional medical system and the local administrative system. So my study explores how the restructured rural social system facilitated the entry of the total emergency inoculation schemes into rural villages by making the local agents and household information readily available. It also considers how the inoculation campaign adjusted, improved, and eventually strengthened the newly downsized and restructured people's commune system just after the end of the Great Leap Famine. So my study documents how the downsizing of the production brigades, the designation of the duties to local officials, particularly those of the production brigade and the production teams, and the compilation of the household register and implementation of the new payment schemes greatly facilitated the state control over rural areas and theoretically provide efficient local officials and accurate demographic information for the inoculation program. However, the emergency inoculation schemes in the summer of the 1962 suffered due to the poor coordination of the local officials and chaotic information on the inoculation subjects. The strengthening of the role of the former and the creation of the reliable inoculation register based on the brigade household register and the team accounting books facilitated a concerted total inoculation campaign efforts in 1963 and afterward. So this is the progress on the cholera inoculation in Rui'an County from 1962 to 1964, because the cholera case was identified in Rui'an. So this was the first county. So it should be noted that mass inoculation campaign were implemented during the next 2 decades of South China, according to the schedules and the rhythms established in 1963. And this preventive inoculation against the cholera was phased out in China in late 1970s and some areas in early 1980s, because the government realized it was not effective to conduct the mass inoculation. So in this study, I argue that the inoculation registers and the certificates generated by these campaigns were very significant for concurrent restructuring of the people's commune system, as the household and the demographic data were much more accurate and reliable through repeated verification. And this process demonstrated the dynamic interactions between the household, accounting, and inoculation registers during a period of significant social restructuring. And this was implemented through the demographic data gathering that was initially designed to verify the population data in order to deliver the health outcome via the distribution of the inoculation certificates. And this bureaucratic process further contributed to the formation of a sedentary society and created a new set of biopolitical data that would encompass the whole society. And functionalized as a population control and a surveillance scheme, all this inoculation campaign and strengthened the emergency disciplinary state in the changing socio-political context. In epidemic surveillance and the statistics during the pandemic had been a thorny issue in the epidemic prevention system of 20th century China, particularly during the era of the Republican government before 1949. So the difficulties of the epidemic reporting caused by the problems of the coordination and the capacity of the administrative and the medical system still haunted the new government after 1949, though the Chinese government quickly established a complete administrative system right after its revolutionary victory. The medical system, which included the epidemic prevention schemes such as epidemic prevention and sanitation stations at the different level. So they did not emerge until the middle 1950s. So that's just 6 to 7 years before the outbreak of this global cholera pandemic in 1962. So this not only posed a great challenge to the emergency response to the pandemic, but also provided a significant opportunity for improving the epidemic prevention schemes through the restructuring and integration of the medical and administrative systems in the socio-political context of the early 1960s, just before the outbreak of the Cultural Revolution. So my study explores the rise of the disease surveillance actions and the politics of the disease statistical collection and how this contributed to the social restructuring through the 3 concurrent process, such as including the institutionalization of the medical system. And the second is the medical regionalization of the administrative systems. And the third is the epidemiological categorization of the populations. So I argue that establishment of outpatient departments for intestinal diseases, the submission of the stool sample for testing, and the control over medical practitioners were three integral steps in the medical institutionalization process in 1963 and afterwards. And the cellularized epidemic reporting based on the vertical downward schemes and the horizontal regionalization of both the professional and the voluntary mass epidemic reporting networks effectively regionalize the grassroots administrative system within the social restructuring that was taking place at the time. So my study also argues that the follow-up stool test for cholera patients, the classification of the patients, the classification of the patients, suspect carriers, the vulnerable groups, and the healthy population, and the creation of the patient archives functioned as epidemiological categorization for different populations. So this process was integrated with the household register, with the inoculation register, and contributed to the rise of the new kind of the statistical politics, which helped shape the concurrent social restructuring. In all, as the new and integral biopolitical control tool, the epidemic statistical scheme quickly developed as a crucial part of an emergency disciplinary state. So the last one is the issue of the control, information control. So last practice involves both of the politics of the pandemic information and historical origin of the tradition of the secrecy around epidemic statistics in contemporary China. The cholera pandemic information was highly politicized in the domestic and international political context of the early 1960s and contributed to the concurrent ground-level social restructuring process. Entrenched supernatural interpretations of the etiologies, religious practice, and the social memory of the cholera pandemic before 1949 posed serious concerns for the communist government in terms of maintaining the social order and the political legitimacy, and even so-called national images or the reputation. So the cholera functioned as a political metaphor, and the effective control of it justified the communist government's legitimacy. As a part of this response effort, cholera was defined as a national secret, like other epidemic and pandemic information of South China, and it was coded as the #2 disease. So that was 2号病. Yeah. Information on it was not only strictly controlled, but also endowed with the considerable political significance. Inside the government system, the top-down dissemination and the surveillance of the pandemic information become a form of the political disciplining of the government officials, and the silencing of the public media and the strict control of information about the cholera pandemic, particularly those statistical data, to the masses, function as the political indoctrination. In the international arena, the Chinese government created an information asymmetry between itself and the international health community, and further endowed information about the cholera pandemic with the political function of advancing the ideological work. So information control has become a key feature of China's emergency response schemes for epidemics and pandemics. In addition to the traditional interventionist methods like quarantine, isolation, and inoculation we just mentioned. More significantly, the political discipline, indoctrination, ideologizing imposed by the cholera pandemic information control scheme had a comprehensive impact on the different administrative system and the social groups, such as the party and the government system, the propaganda system, local officials, medical professionals, and even those are ordinary masses. So during this control process, criticism, self-criticism, punishment, control, and the guided narratives of the were widely applied. As a cohesive and disciplinary scheme, information control became an adjunct political event accompanying the cholera pandemic, one which significantly contributed to the concurrent social restructuring and more broadly, the rise of the emergency disciplinary state in most China and afterwards. So now let's turn to the conclusion, brief conclusion. Disease and its control were not only affected by the social restructuring that had begun in the 1950s and strengthened since 1961, but also integral components of this, the quarantine, isolation, the mass inoculation, epidemic surveillance, and information control, functionalized social control, and political discipline, and therefore significantly contributed to the rise of emergency disciplinary states. So in all, the emergency disciplinary state was composed of the top-down leadership, the vertical bureaucratic system, and the horizontal grassroots social organizations, such as the People's Commune System and the Work Unit System based on the household registration system. Through the centralization of the political power, the dominance of the administrative system, and the cellularization of local society, this regime was an integral and active government entity. The party and the central governments maneuvered nationwide medical resources and personnel in response to pandemic. The medical and administrative system jointly participated in epidemic prevention campaigns, restructured the rural and urban society, facilitated the implementation of the traditional interventionist measures. In general, this process depended on the richness of the medical resources, the integration of the two systems, medical and the administrative system, and the cooperation of the local society. It was not a straightway process. However, once it was improved and routined, the public health response scheme entrenched in this emergency disciplinary state demonstrated its efficiency, aggressiveness, and resilience. The rise of the emergency disciplinary state during the public health emergency response of the 1961 to 1965 was of great significance in the broad historical context. It existed far-reaching impact on its socio-political system and emergency response scheme since most China, such as the COVID-19 we had witnessed over the past 3 years. So that's my presentation. And thank you all.
Thank you very, very, very much.
You're welcome.
Before I open it up for questions, I just want to reiterate the importance of understanding two very important aspects. I think firstly, this presentation kind of throws up history repeats itself. And I think if you look at the control of pandemic across the world, like you rightly said, whether it's plague or any of the others, cholera being one very important one, and of course SARS and now COVID, you find that the political response and even the decisions that are made are political. And I think the point that you raise about the rise of the emergency disciplinary state is very, very critical when you look at how pandemics are, one, managed, how they reconfigure social relations, and also curtail mobility and who is included, who is excluded. And of course, in the Chinese case, the complete separation of the rural and the urban. But I also think it's very, very interesting in your initial part of your presentation, how you look at this event of the Indonesian Chinese coming back to mainland China. And actually, it is the Chinese government, and in your book, you have a very vivid description of it, of, buying ocean liners, renaming them, and then sending them out to actually get the Indonesian Chinese back. And you see a certain globalized interaction of population movements that then lead to this pandemic. And I was particularly interested in, when you talked about the rise of emergency disciplinary state, of the decision over inoculations. You see, we are in, actually, as you present this, your work from China, we're in the midst of a global emergency of cholera. And the WHO is taking cognizance of it. And the debate continues today. Should we go in for mass inoculation or not? And it was interesting in your presentation, you made this point that there was a conversation within the Chinese medical community. How efficacious is inoculation in the case of cholera control? And clearly, the politics then make a certain kind of a decision, and then you reconfigure, you use all your administrative apparatus to achieve it. It was very similar in the COVID pandemic.
Yeah.
So when you talk about China, I mean, it was a bit chilling for me because we witnessed in the COVID pandemic, even in the Indian context, the emergency disciplinary state and its various aspects very, very vividly. So I think I just want to stop there, and I'm sure there are other questions, but thank you very much, because there's a lot to think about. Yeah, thank you. Any questions, comments? I think if there are none in the chat box, people can just sort of intervene. Rapai,
there is a question from Rija, ma'am.
Okay,
yes,
let
please
me take
Thank you, Dr. Shopping, for a very interesting presentation. So my question to you is regarding what you had mentioned in your initially in your presentation about Indonesian Chinese migrants, coming back to China, coming back to mainland China. And also this is a period when you see a lot of dislocation and migration happening, right? With the Great Leap Forward and the various political campaigns, you see a lot of dislocation happening. So I was more interested in knowing about, what is the kind of discourse happening about migrants during this particular period?
Okay, so actually there are around two questions, right? The first is about the Indonesian Chinese.
Right. In the context of migration, so I mean, what is the kind of discourse happening around migrants, given the fact that, that it's a period of pandemic. So what kind of discussion is happening about the migrants?
Okay. Yes, I know.
You see that in the current scenario also, with the COVID-19 also, like migrants were seen as, carriers of the virus, looked at with suspect. So I was just kind of trying to understand this.
The first about the official discourse about the migration of the returning Indonesian Chinese. So in my presentation, I mentioned this Indonesian Chinese returned to China because the political disputes between the political, social, and cultural dispute between the Indonesians and the Chinese broke out in late 1950s, but they were suspected cholera carriers. And after the outbreak of this cholera in 1961, the governments conducted epidemiological investigations, but the discourse is that the governments did not publicly announce that was brought by the returning Indonesian Chinese, because the Chinese government's accommodation of the returning Indonesian Chinese showed the legitimacy of the Communist Party. So showed that the Communist Party was quite different from the previous government, like the nationalist government before 1949. So that's quite that involves this discourse involves the relationship between the migration, race, and politics and the pandemic. So that's quite complicated. And for the migrants, you mean during the Great Leap Forward and the cholera epidemic, right? Actually, yeah, in my book, in second chapter of my book, I have already analyzed these are the movements of these migrants, because a lot of the peasants went to the cities or other rural areas, but these movements was not so organized in government's eyes. So that's after just around our outbreak of the cholera, governments try to contain these so-called unorganized population movements. So during the cholera pandemic from 1961 to 1965, actually there was no much movement, population movements. Even those are people living who live and work in urban areas. As you know, in 1958, the government has already started implementing the household restriction systems. But after 1961 and 1962, the government implemented this policy very, very strictly. So actually, there was no much migration or movement. And I think the official discourse also usually criticize this movement.
Thank you, Dr. Xiaoping.
Yeah, so I'm not sure whether I answer your question.
Yes, yeah, that answers the question. Thank you.
Welcome.
I think there was a raised hand from Rapai, sir.
Rapai?
Yeah, I think I can come in. It's not just I wanted to some comparison. You now talked about the Indonesian Chinese. In our experience, the 1918-19 flu epidemic, how that spread into India from the soldiers who returned from the European theater. And slowly it spread to the rural areas. Like that, I think China have some, but China may be better in collecting and keeping the data. I don't know how much we made use of our old data in the 1920-21 COVID epidemic. But I think the one way the medical fraternity, the doctors and the allied systems, they experience how the Chinese record keeping. Can you throw a little, because you've done wide research in China about the 1962 epidemic or the cholera spread, how that the knowledge is passed on to the posterity. Thank you.
Oh, yes. Regarding the collection and the recording of this data, I just now I mentioned the government, after 1949, the government has established a top-down administrative system reaching the village. So it was quite efficient, efficient administrative system. And in the meantime, the governments also established, try to establish the medical systems, which is affiliated with the administrative system. Both systems, both of these two systems were top-down and efficient. To my knowledge, the government can collect the information very effectively, but unfortunately, the government classified this information concerning the epidemics and the pandemics. So it was very time consuming to collect these documents.
Okay, thank you.
You're welcome.
May I just come in? One of the things that in the present discourse on China is that China is not transparent in sharing its data. I mean, this is something, especially after COVID-19, this has been reiterated by the global community. And as you know, it's been accused of not sharing data, not having transparency. To what extent was there transparency in sharing data? Because you said that it was a confidential.
Oh, yes. Yeah.
So, I mean, so what was it? So you may have collected very good data, but who was looking at this data? Who was using this data?
Well, the government creates a very unique schemes of collecting and distributing all the information concerning the epidemics and the pandemics. For example, in the case of the cholera epidemic, government compiled the documents or the books about the statistical data of the cholera, and then they distribute the book to the local governments, and each book was giving a specific number. So government know who received this information. So it's very simple, but it's very effective for the government, and they can control this dissemination and the flow of the information.
Yeah, I think, Professor, when you shown that it was marked teeming. Teeming is, I think, it is more than the ordinary classification. Those items you will not open unless the government decides to open.
Oh yes, definitely. Yes. Yeah. It's up to governments.
Yeah. Thank you.
Welcome.
There's a question in the chat box.
Okay.
Yes, Ambassador Rana has a question. He's saying, I lived in Beijing from August 1963 to September 1965, and I really don't recall a major epidemic at that time. Was it really a big event? We did go on diplomatic tours at that time, but never noticed an epidemic. So this is Ambassador Kishan Rana, who has spent time in China.
Oh, thank you for your question. Yes, there were no cholera cases in Beijing. The cholera first broke out in Guangdong in 1961, and then spread from Guangdong, Zhejiang, Fujian, Shanghai. And then the cholera stopped spreading in the mouth of the Yangtze River around the Nanjing. So it did not spread to northern China, but there were a few cases in Tianjin, and there were a few cases in Xinjiang, the Xinjiang, northwestern part of China. But there were no cases in Beijing. And the government controlled the information. So there were no reports, public reports about this pandemic in southeast coast of China from 1963 to 1965. And even in Hong Kong, in Hong Kong, there were many refugees from Guangdong. They fled from Guangdong and went to Hong Kong, and the Hong Kong government interviewed these Guangdong refugees, and knew there was a cholera pandemic in some counties in Guangdong province in 1961 and 1962. So the government, government successfully controlled information.
Thank you, Dr. Xiaoping. We have a raised hand from Professor Alkacharya.
Yeah, hi. So thank you very much. It was indeed extremely interesting, absorbing lecture. And it sort of comes out of what you just said in response to Ambassador Rana's question. I'm interested in knowing what are the continuities or departures from the Mao period to now in the context of center and provincial relationship. To what extent do provinces have autonomy to, let's say, evolve their own strategies of dealing with problems at the local level? And to what extent do they have to follow orders from the top? So do you see any sharp departures from, say, the Mao period to now?
I don't think in my opinion, I don't think these are a departure over the past decades, and I don't think the local governments, such as the provincial governments and the county governments, can have the autonomy in containing this the pandemics. I don't think they have such autonomy. So I mean, this continuity of this pandemic control practice.
I think Alka's question is very important, because you see, it's one thing to have a small epidemic which you can control in a local context, right? But if you look across the world, any large epidemic which then moves into a pandemic, you find the rise of the emergency disciplinary state. And I think that is a very important takeaway from this lecture, that in a sense, a public health event of a particular disease outbreak has the potential for great state control and a legitimization of that state control. Both.
Yes.
And we saw this particularly in COVID. After all, state governments had very little say in the policies to be adopted for COVID control in India. Although in India, we have a much more, many more powers to prevent what is equivalent to provincial governments. But the tension there was that the entire thing had been centralized to such a large extent that they couldn't develop their own protocols. They couldn't regionalize their demands. Everything was reported to the central government. As a result, there was one size fits all, and then there was this complete control. So I think if we examine many countries, you will find that a pandemic actually becomes very convenient to unleash a lot of very undemocratic policies. It legitimizes it.
Yeah, absolutely. Rama, you got the point that I was trying to make, that broadly, does the nature of a pandemic actually intensify these undemocratic practices? And in China's case, we already have the degree of control to a large extent. So what really are the dynamics at the local level? How do people actually find ways? Can they find ways to expand their autonomy and somehow address local problems at a local level without being completely controlled? I mean, those are the questions that were in the back of my mind as I was asking this.
Yes, the COVID. Oh yes, the COVID-19 pandemic governance models continue the traditional interventionist control emergency response in most China. So just what I mentioned, we see the aggressiveness and the resilience and the continuity in terms of this practice.
In fact, a colleague of ours had during the COVID period, and even before the translation came out, had discussed the Fang Fang diary as really, which demonstrated the kind of state control and pressure on people's lives.
Yeah.
You know, so I think Hemant, if he's here, he may wish to add to that. But these are aspects which then you start seeing shades of it in different parts of the world, you know, across different political regimes as well.
Ma'am, I don't see any raised hands or questions in the chat box.
So if there are no further questions, should we close the session?
Sure, ma'am. Yeah.
So will you give some concluding remarks, Rama, before we have
Yeah.
our MC coming into?
Yeah. So I think we've had a very interesting presentation, a discussion which was fairly complicated, as we can well imagine, that you use the lens of public health, a particular disease, a pandemic, to really talk about how it is not just some kind of a technical public health discourse, but actually you see the socio-political reconfiguration, you see the rise of emergency disciplinary state. And I think many of the things, and you also, and if you read his book, you will get a sense of this, which is the choice of scientific tools. So they are not value neutral either. And, you know, that these become political decisions, and how, therefore, certain scientific evidences which may be contrary to a particular strategy just get sidelined. And the inoculation story is a particularly important case, as was mask wearing during COVID. Now, in fact, WHO has gone back on its advisory that you should not wear masks. You don't need to wear masks. So, you know, this kind of issue does become very important. I think, secondly, it's we need much more work, and there is work around plague. There is work around influenza pandemics. I think those really come from the area of history of medicine. And it's very, very fascinating to be able to hear you today, Xiaoping, and I'm very glad to hear you. But I'm going to make a request to you, which is that I would, at some later point, invite you to speak on your work on barefoot doctors, which I think is so fascinating. And, you know, we all sort of romanticize the barefoot doctors globally today. But I think you bring in many, many dimensions to this cadre of workers, and their training and their engagement with the community during the collectivization and the decollectivization phase. So with those...
Rama, just a brief word here. The Barefoot Doctor scheme has a very interesting linkage with India, you know, when we had...
So we took that idea to transplant it in our context. I mean, there were many problems, but and even today we have frontline workers who are women, very much modeled around the idea of barefoot doctors.
But so I think, Rama, Kerala health workers, the rural villages, health workers are working, and really it is giving results.
It is, but they're also highly exploited. I mean, I think that's a very
of course that is a
they're underpaid.
That is a serious issue. But I'm telling that, but their role is
of course
very effective in the panchayat level.
Of course, they are. But I think there are these other aspects to it, which. So thank you so much, Xiaoping, and we look forward to meeting you again. And also for us to collaborate much more. And Dr. Acharya is here. We had a conversation before the seminar began, Alka, that we will revive this at an MOU between the Chinese Studies Center in Monash and the Institute of Chinese Studies.
Yeah, it's my great pleasure to give a talk about the barefoot doctors.
Yeah,
very, very, very welcome suggestion about the MOU. I think this is such an important area.
Oh yes, we Monash Arts faculty has just established a health humanity major. So we are around 40 faculty members across different schools under the Faculty of Arts, and we some of them are from, I think majority of them are from School of Social Science, and some of them are from School of the Language, and even the School of the Performance and the International Studies.
Excellent.
So we look forward to discussing about the collaboration on the health, humanity, or other issues.
Okay. Yeah, that'll be wonderful.
Yeah, thank you.
Thank you very much. Yeah.
Welcome.
Bye-bye.
Thank you for your time. Yeah.
Thank you. Bye-bye.
Bye.
I seek your permission to bring today's session to a close. With this, we shall wrap the session. We thank the speaker and the chair for gracing the event with their presence and for giving us their precious time. The video for today's discussion shall be available on the ICS YouTube platform. At the ICS, we conduct seminars every Wednesday, and information regarding the same is available on the ICS website. You may also subscribe to our newsletter for regular updates. Next week, we shall be having a panel discussion on China and the Middle East. We hope to see all of you there. Thank you so much.